morning to everyone present. Today I'm here to discuss our work on the topic Progression to Bilaterality in Unilateral PCG done at Dr. Rajendra Prasad Center, AIIMS, New Delhi. So as we know, the incidence of unilaterality in PCG ranges from 15 to 35% in published literature, and the unaffected healthy fellow eyes of these individuals are believed to harbor form fruste of the same disease. However, there had been no long-term incidence study to see how many of these initially unaffected fellow eyes eventually develop a rise in IOP or frank glaucoma. On reviewing literature, we could find only two studies, one done by Dr. Bayoumi in Egypt, in which there was a retrospective review of 56 unilateral PCG patients, in which they found that the unaffected fellow eyes differed when compared to healthy control eyes in terms of having higher IOP and higher CD ratio. And the other study done by Dr. Zia, which was a retrospective review of 7 patients over 17.8 years, in which they found that none of these fellow eyes eventually developed disease. So the primary objective of our study was to address this lacuna in literature to evaluate the incidence of rise in IOP in the fellow eyes of unilateral PCG patients and to see if we could identify any risk factors and to correlate these with ASOCT findings. We included unilateral PCG patients who had a minimum of 5 years of follow-up in our glaucoma clinic and then called them for a review examination and collected their clinical parameters. In our study, we defined progression to bilateral disease as an increase in the IOP to more than 21 millimeters of mercury on 2 occasions, either without an increased cup disc ratio, which was termed ocular hypertension, or with signs of glaucomatous optic neuropathy, which was termed frank glaucoma. High resolution ASOCT images for the angle structures was obtained, and we looked for the presence of markers of angle dysgenesis, namely the absence of a clearly discernible Schlimm's canal and trabecular meshwork, and the presence of a hyperreflective membrane covering the angle recess, the putative Barkhan's membrane. We also looked for the presence of a patent supraciliary channel, which in some studies has been hypothesized to serve as an alternate route for aqueous drainage. Coming to our results, we were able to recruit a total of 54 eligible patients, and over a median follow-up duration of 8.2 years, we found that a striking 31% of these initially unilateral eyes progressed to bilateral disease, with 15% developing ocular hypertension and 17% progressing to frank glaucoma in both the eyes. Most of these patients were found to develop bilateral disease in the age group of 5 to 10 years. On comparing the dysgenesis parameters on ASOCT between the affected and fellow eyes, we found that they did not differ significantly when we compared the absence of Schlimm's canal, the absence of trabecular meshwork, or the presence of the hyperreflective membrane, thus suggesting that these eyes harbor a similar level of dysgenesis from the beginning. However, on comparison of the patent supraciliary channel, we found a significant difference, and with the presence of this channel, the odds of not progressing to bilateral disease was found to be 1.48. On comparing the risk factors for progression, we found only one factor, that is the corneal diameter of the fellow eye, which differed significantly between the progressor and non-progressor group. And with fellow eye corneal diameter of more than 12 mm, the odds of progression was found to be 9.5, which was statistically significant. When we compared the ASOCT parameters between the progressors versus non-progressors, there was no difference, suggesting that these parameters cannot be used to predict which of the fellow eyes will eventually develop disease. To conclude, progression of unilateral PCG patients in our cohort to bilateral disease was found in 31.5% patients, 15% developing ocular hypertension and 17% developing glaucoma. Corneal diameter of more than 12 mm emerged as a strong predictor as to who will develop bilateral disease, and the presence of a patent supraciliary channel could possibly be protective, emphasizing the need for regular follow-up with close evaluation of these fellow eyes so that early detection and timely intervention can take place. Thank you.
Yeah, thank you, Dr. Aayush. Yours is a PG thesis, right?
Sorry, sir?
It's a PG thesis.
Yes, sir.
But you said the follow-up is for 8.2 years.
Yes, sir.
So how come this was done in 3 years' time?
So this was an ambidextrous study. Most of these were retrospective patients who were already following up in our glaucoma clinic.
Correct.
So we chose those patients who had a minimum of 5 years of follow-up already, and then we called them up for a review examination.
No, but
so
ideally, thesis should be prospective, right? It cannot be retrospective.
Sir,
ideally.
This was an ambidextrous study. We were recruiting new patients as well.
Yeah. When you do the initial eye examination, did you do ASOCT both eyes?
Not in the, sir, when at the time of presentation, first presentation of these kids, they were usually infants who could not cooperate for ASOCT. These ASOCT images were taken on the last follow-up examination in which we had called these patients, and only those patients who were cooperative enough for ASOCT were included in the study. Sir, age-wise, we could see that even older kids, like 7 to 8 year olds, some of them were not cooperative for ASOCT, and even younger kids sometimes, when we forcefully put them on the ASOCT machine, they were able to cooperate. So I believe the bias of age versus this ASOCT acquisition did not matter.
Do you do any examination under anesthesia?
Sir,
in
examination
patients?
and anesthesia was done at the baseline level and also at the time of surgical intervention for these patients in the initially affected eyes.
Do you do the gonioscopy in both eye, any stage in baseline?
Not for every patient, sir, but yeah, gonioscopy, intraoperative Swan Jacob gonioscopy was done in most of the patients, but we have not included gonioscopy parameters in our study. UBM, actually, sir, since it's a retrospective, yeah. No, on the follow-up examination in which we have done the ASOCT imaging, it was not done under anesthesia. You're saying UBM on an office basis? That was not taken as part of our study, sir. We did only ASOCT imaging. Yeah. Sir, because ASOCT, even though
Right. Thank you, Dr.